And this is our fourth and final lecture revolving around mitral stenosis. With this lecture here, we'll investigate the PISA method and how it has application for both regurgitation and stenosis. There are, however, specific considerations for its approach when we actually apply it with stenosis. Of course, there are the limitations and considerations that we need to apply when we actually use this method. When addressing with corrective procedures, such as valvuloplasty, there are also considerations that need to be made. It's important to establish when this corrective measure should actually proceed, and that comes down to the findings we actually have with the sonographer. The proximal isovelocity surface area is based on the same principle of conservation of mass. It is important to note that many students misinterpret the isovelocity as isovolemic from previous physiological learning. This calculation makes the assumption that flow through a regurgitant orifice is equal flow within a hemisphere shape. A radius is measured from the valve leaflets to a hemisphere or dome, which is made when colour is applied with specific settings. We know that a hemispheric area is equal to 2 pi r squared. We're using a specific velocity defined in the machine to determine the radius and thus our hemisphere. The velocity at this point is neither accelerating or decelerating. It is uniform or unchanged, thus the term isovelocity. However, blood is accelerating as it moves closer towards the orifice. Therefore, higher velocities equate with smaller radiuses. As blood progresses towards the stenotic orifice, it increases in velocity and hemispheres associated with each velocity progressively decrease in size. The specific velocity at any hemisphere is uniform. So we know that flow through the stenotic valve is going to be equal to the flow within the hemisphere. We expand it out to cross-section area times velocity, and then we substitute it across. We can then take that the cross-section area is equal to the effective orifice area. PISA may be used for mitral stenosis, which is all fine except for when mitral stenosis is of rheumatic type. In this specific pathology type, the valve leaflets billow in the direction of flow, so there's the appearance of an effective funnel shape during flow. To measure the radius from the leaflet orifice and to place a dome over the top makes the assumption of a formed hemisphere incorrect. The actual area within is less. So to adapt for this, we include alpha, the angle, into the equation. In this example here, we can see colour flow of blood moving in from the atrium into the ventricle. So a radius would actually be measured from the leaflet tips to the first level of aliasing. And in this one here, we can look at the forward flow through the valve. Now it's important to note that even though the atrial component has the higher velocity, the velocity we're actually going to measure is from the early diastolic flow. Putting it all into practice, if we had the various sets of numbers where the radius is 14.2 millimeters, the aliasing velocity, and the velocity through the valve, the angle can either be actually made by the machines if the machines actually allow for it, or the sonographer needs to grab a protractor, apply it to the screen, and measure the angle itself. Throwing it all into our formula, we obtain this, and note we've actually done a conversion of some of the units to get them all into centimeters. So effectively, our orifice area is 2.4 centimeters squared. And again, there's limitations and considerations when we actually apply the PISA method. The orifice, particularly for mitral stenosis, is elliptical in shape and not circular, and thus a hemisphere will only approximate the volume of blood within inside this dome. Now that an angle is introduced, there's a potential for incorrect measurement, and the fact that some ultrasound systems do not have this capability as part of the measurement package. A protractor must be placed on the screen and manual alignment may be required. The mitral valve is also saddle-shaped, thus measuring in one view may not give an overall representation of the angle as formed in stenosis. As with the limitations seen with other stroke volume calculations, the radius is an important component, and error in the determining of this value will lead to inaccurate valve areas. The radius is measured at specific points in time, such as early diastolic filling for the mitral valve. An effective orifice estimate is made with flow at that point in time. This may over or underestimate the true anatomical orifice area. Beat to beat variation is seen with previous calculations can lead to error. Thus, it is important that numerous measurements are taken. Even in sinus rhythm, a sonographer averages 3 to 5 measurements will deliver a more desirable result when only a single point is taken. In the presence of atrial fibrillation by Germany or very frequent ectopic beats, then up to 8 measurements will deliver the desired accuracy. There are also considerations for determining of hemispheres. The isovelocity contours, or effective shells, flatten immediately proximal to the orifice, effectively changing the shape of the assumed volume within will be incorrect. Using a baseline shift that is not too extreme, i.e. a high velocity prior to the ASing, minimizes this effect. Additionally, the orifice shape may be irregular, so the hemisphere doesn't accurately represent the shape of the flow convergence. Structures do not remain stable in the imaging plane throughout the cardiac cycle. This is of particular importance for the atrioventricular valves in systole. In systole, the ventricle contracts not only circumferentially but also longitudinally. As a result, the atrioventricular valves descend towards the apex in systole. This motion will add to the isovelocity of a hemisphere, making it effectively larger, and thus a user will overestimate the severity. The effect of this is minimized when the appropriate baseline shift is used. Extreme shifts with very low aliasing velocities enhance this unwanted effect. When we actually have mitral stenosis, one of the common methods for correcting it is to use a valvuloplasty. We have the MGH or Wilkins score that we can use to assess whether this is actually going to be a viable method to correct a stenotic lesion. We look at 4 main factors: leaflet motion, leaflet thickening, leaflet calcification, and subvalvular thickening. And these range from basically normal or almost normal to extremely severe. As we could suggest here with leaflet calcification, so a 1 we would scale for just focal calcification at little points, and then 4 being the extreme, extensive invasive brightness that actually goes throughout much of the leaflets. So as we mentioned, we score 1 to 4 for each of the categories above, which gives a potential range between 4 and 16. An ideal score to actually progress with valvuloplasty is 8 or less, although a higher score is not always a contraindication. In our example here, we have a 45-year-old male. He has a 2-year history of increasing shortness of breath on exertion. He's had several episodes of atrial fibrillation. However, this particular scan is in sinus rhythm, and now we're actually considering for the balloon valvuloplasty. Here we have the example of the mitral valve. We can see that there's a calcification on the leaflets. We've got this typical doming, this thickening and shortening of the cord A2. So with this particular patient, we score the patient as follows. So leaflet mobility is actually reasonably good, a low score. There was significant calcification of the leaflets, a higher score of 3, moderate thickening, score of 2, and subvalvular involvement was actually quite high, a score of 3. Thus the total score we obtained was 9, so in a less desirable area for actually proceeding with actually valvuloplasty. It is important to note that stress echo may be actually applied in the presence of mitral stenosis. The evaluation of functional capacity may be useful for a surgeon. Does the valve require corrective procedure? When is it most appropriate to replace the valve? Are some of the questions that can be asked. These can be answered by evaluating the patients with exercise tolerance. The poorer the exercise protocol progression, matched with marked increased shortness of breath, suggests intervention is warranted. Post-exercise imaging will assess the pulmonary artery systolic pressure, the peak and mean mitral inflows, and RV systolic function. Marked increases in the pulmonary artery systolic pressure and decreases in RV systolic function further indicate the valve is significantly problematic. Pearson's application for stenosis is a useful tool in conjunction with other methods. It is a simple and quick method to assess the valve. There are, however, many pitfalls to be wary of. And finally, the Wilkins or MGH score is frequently used by cardiologists to assess the suitability for valvuloplasty. There are, however, no defining points for the gradings between 1 to 4 from mild to severe, and therefore there are significant interoperative variances that exist.